Fluid line doesn't get, it just comes out there.
Let's come out here.
Yeah. Hi guys, this is Charles, one of the surgeons at the Animal Emergency Center in Moorabbin. Can you turn off the surgery lights, please? Just that one switch. So I've got a very cute 4-year-old dog that has a history of about 2 weeks of left hind limb lameness with cranial jaw instability, and so we are doing a Tplo today. But first, we're going to do arthroscopy to have a look. Just a lot of fluid that just poured out of that joint. So we're going to do arthroscopy to confirm our diagnosis and to check the meniscus. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. I'm looking for the scope port. So again, a 4-year-old dog. Is that therapeutic? That's the one I need there. That's the one that you have. Yeah, that's therapeutic. That's the correct one up there. Yeah. So 4-year-old dog, cute onset of lameness, very cute, nice owners. Owners are doctors. And so we are about to stick the scope in here. Okay, so I'll just go in, go up underneath the patella. Okay, and then I'll stick the camera or the telescope in. And we'll get our light guide connected. And can we get the light turned on, please? Yeah, should be. Can you hold on? There, so saline should be running. Everything's turned on? Okay. All right, so just looking in the joint here. So push that down for me, please. All right, so now we're looking at the caudal cruciate ligament right there. Just need to focus a little bit. So that would be caudal cruciate there. That looks like cranial cruciate ligament right there. So that's just a great view. Cranial cruciate there, and then we'll look at the medial meniscus over here, but I can't quite see it yet, so I may have to get the shaver going. So if that had been medial, probably my initial response would have been, oh, that's a meniscus. All right, so then looking across here. So that's all infrapatellar fat pad. Thank you. A bit muddy. Let's get this. All right, so I'm just trying to find my shaver blade. I can feel it. Ideally, you don't really want to shave until you can see the tip so that you're not shaving the end of your scope off. Okay, and the suction's turned on. Okay, so there's my shaver tip right there. And that's my medial condyle. Right there, just shaving out a bit of the cruciate ligament. All right, so where are my probes and things for my stifle? That's looking like it might be a meniscal tear right there. I'll probe it in just a second. That is just such a nice image. A little bit of bleeding there. And I can't really answer your questions just yet. Can you grab those, please, for me? So that's the medial epicondyle, and that may be a meniscus right there, or it may be residual cruciate, and I can't tell until I get the probe in. Okay, I'll have you come back over, please, Cindy, and hold on to the knee. All right, so now I'll drop the probe in. Okay. Okay, so there's the probe right there. I'm pulling that forward. And is there enough pressure on the line, please? Yes, please. Okay. Yeah. I think that is all torn meniscus there. I'm try to shave that out. And there's a chance that we'll have to convert it into an open mini-arthrotomy. Just turn off the suction until I can see. Okay. Okay, and I'll get that probe back in there. There's no post-op plan that you can do to reduce recurrence of PU. You have to just, the only reason why you get recurrence of stricture with a perineal arthroscopy is because you haven't dissected up far enough. So it's not a post-op plan, it's just making sure that you dissect up far enough past the bulbourethral glands. Okay, so that's all still meniscus right there. So I'm just trimming out all that meniscus. And the scope takes a little bit longer, but it's really nice when you're finished because you don't have to close anything. So I'm just shaving out that last little bit. Okay. Let's get the probe back in there. Extend a little bit. Still a bit right there that I will have to shave out. Extend a little bit. Yeah, that's great, thank you. Where's my condyle? A little bit of cartilage damage there. I just leave it exactly where it is. All right, I reckon I'm going to do just a little mini-arthrotomy just to make sure that I've gotten everything out. Can I get some little gelpies, please? Get the light turned on. Yep. That's great. And then just push the button on the console. Here, over here.
Oh, yeah, sorry.
Yeah. Thank you. And then some surgery lights, please. I can turn them on. That's all right. Oh, if you could turn them on, that'd be great. All right. So just bring this up like that and hold that, please. And so I'll do just a little mini arthrotomy through my same hole. And I do have a lot of courses, but Vet Dojo e-learning platform is kind of in a hiatus right now while we figure out what we're going to do, or well, I figured out what I'm going to do with it. You can't actively register for any courses.
Just when you're moving the table, just maybe don't touch this corner. Okay, sure. Because like, yeah.
Okay, section's turned on. And where is my tip? Now there is still a little bit of, and it's amazing that when you look in here, the damage that was so devastating on the scope, you can't even see grossly. So it just gives you an idea of how magnified it is and how much worse things look. Okay. Yep, hold on to that. Sorry if my head's in the way. It's going to be there for a couple of minutes. Okay, so I've got that little bit of meniscus now that I could see, which is actually quite tiny. And I think it would have been fine even if I had left it in. So that's just that little bit of meniscus right there. Can I get some little tiny rongeurs, please? Thank you. I'll take some 2O PDS, please. Okay, that looks great now. All right, so just going to do a little closure of the fascia lata, maybe just a couple of sutures. Now, pain relief wise, we have done a nerve block on this dog already, so we don't need to do intralesional. All right, so while I'm opening up the joint, the metaphysis of the bone, you can go ahead and let that go. Can I get the table up, please? I will hand off all of the equipment except for the cautery. A little bit higher, please. Go ahead and hand off all of that equipment. Yeah, that's great. Thanks. Okay. And I'll just move the camera. The telescope, yep. So I measured this as 27-degree angle. And it'll be a 24-millimeter blade. Let's go ahead and get all the other equipment open, please. So now I'm just exposing that proximal tibial metaphysis. And it was a fairly acute rupture, so we don't have a lot of medial buttress. Maybe just a little bit. I have to be really careful for the collateral ligament, which is just right there.
You want some overseas needle?
Yes, please.
Overseas needle. Arthroscopic.
So that's collateral ligament sitting right there. 24. I'll just zoom in. and get a little bit better color definition. So regarding scabbing over on a PU, you can have a blood clot that forms there, and that's something that you do have to watch out for as a possibility. So I'm just trying to define my joint surface. Okay. I'm just getting my saw out. All right, so we'll get a home and retractor up underneath that patellar tendon. Okay, so can I get you to hold on to, we'll just wait for the last little bit of equipment. Saline, please. Let's see what's going on there. All right, so and I don't measure my D1, D2 because I've done so many of these. I kind of know where the cut's meant to be. And so certainly if you're just starting out doing them, doing those measurements would be really helpful to get, to standardize your cut. So I'll make my proximal mark right here. And then I need to measure 27 degrees on a 24 mil blade. So 27 on a 24 is 9.3. So I'll get my caliper. So that's my caliper right there. So put it in my first little divot there, and then measure to the second. So there are my two lines. And I'll remeasure to make sure that I'm happy, and I am. So then I'll complete my cut. Yeah. Okay, we'll switch to our wire driver, take out the Just make sure that my osteotomy is complete. And I'll get a 7/64 inch pin. Okay. All right, and then we'll get a 5/64 inch pin. I'll just get that started for Cindy. Okay, hold on to that. I'm not getting enough rotation here. Can you get that gauze sponge, please? Okay, go ahead. Yep. Okay, stop. Okay, yeah. Okay, keep going. Okay, good. All right, so now we'll take this one out.
Take this out.
Sure if the leg's on straight. It is. All right, and then I'll need my pointed reduction forcep. Okay, and then all right. So the two needles that I put in, can you hold on to that leg for me, please? What plate are we going to use? This is the two needles are for me to tell where the joint is. All right, so I need some K-wires. It's not going to go through there. So I need smaller K-wires. So I'll just use my, do you see the needles?
Needles you need two?
No, just one.
One.
So now I'm just checking to see where my joint is. It's up there. And I'm using temporary fixation pins just to keep my plate in the correct position. That's too big. Thank you. All right, so happy with that. So we use 2 because the joint surface is not perpendicular to the shaft, it's tilted. And so depending on where you measure, you could be underestimating the location of the joint surface. So we want a 2.5. And a drill guide. Measuring 4. That is not correct. Get it 20, please. Yeah. Let's pull that. Let's see. And so I'm not going to tighten this all the way down. I'm just putting it down far enough that it puts the plate flat on the bone, like that. That'll be a 20. So the pointed reduction forceps are called just that. They're just called some people call them point to points, but they're just pointed reduction forceps. And they have several different designs. And you would just look at pictures and decide which ones you want. All right, so now we'll switch to a 2.8. And I might go ahead and pull these pins out. Just to get them out of the way. And my drill guide is here. So the first screw I put in is in the top. That's a 2.8?
Yeah.
And that's going to allow me to tighten my loaded screws. We'll switch that over to a screwdriver. So that's going to be a 36.
36.
Yeah. I'll tighten that one by hand. And then I'll tighten my locking screws, my loaded screws. To really compress that osteotomy. And we'll check again to make sure the leg's on straight, which it is. All right. No, we need two fixation points on each side before you can take the pin out. Just switch that over to a screwdriver. 42, please. And back to our drill. Tighten that by hand. Now we've got that compressed. Got 2 fixation screws, top and bottom. Our osteotomy's completely compressed there. You can get compression if you put a locking screw in first and then your loaded screws, but what I find is that it's harder to confirm your plate position because the locking or the loaded screws pull the plate down really nicely against the bone, whereas the locking screw does not. And so if you put your locking screw in first, it could be floating off the bone a bit more. I need my drill guide. Thank you. I can remove my pointed reduction forceps and my .30, please. Thank you. Tighten that last one by hand. And I'll leave Cindy to do the last one. And I'll go over and check the stream to make sure there aren't any questions. I don't use iodine film because what they've shown in the literature is that if that iodine film comes up at all, it's actually worse than not using a film at all. And on all of these dogs, on all TPLOs, that film is going to come off. So there's potential for it to trap bacteria in there. So that's why I don't use, that's why I do not use a iodine film. Now there's a question about my friend's dog underwent a TPLO surgery, and during the procedure, when cutting the bone with the saw, they accidentally did not apply irrigation. Now 2 months after the surgery, the osteotomy appears to be resorbing and progressing to a non-union. The gap currently seems to be about 3 to 4 millimeters. There are no signs suggestive of infection. So what's happened is that it's killed the bone with the heat. And so what has to be done probably is to go into the osteotomy, curette it out, and then fill it with bone graft, would be my guess, in order to get it to heal. If there's any evidence of instability, then they need to replace the plate and the screws and do the whole thing over again. But if there's no evidence of instability, no rock brack of the proximal segment, then just a bone graft, I think, would be helpful. I'm just looking to see if there are any of the questions. Monterrey, Mexico. Sedatives. So we used acepromazine and methadone as our pre-med, and then used alfaxan as our induction. And then we're on isoflurane. We did a nerve block, femoral and sciatic nerve block, prior to surgery, and that seems to have worked because we're on 1% isoflurane. So Cindy did a great job on that. Hi, Nigeria. So there's a question, I don't quite understand. How can you release the meniscus probing from the front of the knee when the bucket handle tear occurs caudally? So what you're doing, you're releasing the meniscus by either reaching caudally and cutting that caudal meniscotibial ligament to free it up, or some people will make just a radial cut caudal to the medial collateral ligament. And Dr. Anil, I will see you in India. Hi, Sudan. And hi, Missouri girl in Madrid. As far as solution that we use to scrub, we use Chlorhex scrub to start with, and then we use a chlorhexidine alcohol rub after the chlorhexidine scrub, and then we repeat it in theater, and then we use a spray at the end just before we start surgery. All right, well, that's pretty much it. So if you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream, and we will see you again soon.